Okay, welcome to In the Trenches. Today we're going to give a very quick chalk talk on arrhythmias. As my medical student recommended, this is a broad topic. Okay, so obviously with arrhythmias, you break them into two categories. Tachy, Brady. Tachyarrhythmias you break into two categories, SVT and VT. Tachycardia is anything greater than 100. Okay, SVT, you have different flavors. You have sinus tachycardia, the most common, AV nodal reentrant tachycardia. Subgroup of this would be WPW syndrome, atrial fib, flutter, typical multifocal atrial tachycardia, and then there's other atrial tachycardias. Okay, VT, there are different flavors, but there's only one VT. Okay, then bradycardia, you have sinus bradycardia, and you have various type of heart blocks. Okay, so tachycardia, number one, obviously, somebody you examine them and they have a rapid heart rate, you're going to get an EKG, and the patients in cardiac arrest are going to be placed on a monitor. So the first thing you need is an EKG. With any type of tachyarrhythmia, you want to rule out ventricular tachycardia because this is a lethal arrhythmia, and this could go into VFib. And this is how many people die. So you want to look at the width of the QRS complex. You want to look for AV dissociation. You want to look for capture beats, infusion beats. And if there's a question whether this is VT or SVT with aberrancy, whatever, you're going to treat for VT. And if somebody's lost consciousness, the first thing you're going to attempt to do is cardioverter, and then give them intravenous medicines like amiodarone, lidocaine, and whatever. Special type of ventricular tachycardia, look for is to decide the points. Turning of the axis, which do the prolonged QT interval, and obviously if you can, you want to find out what medications the patient's on, or if they have any severe electrolyte abnormalities like low potassium, low magnesium, low calcium. That's ventricular. If it's supraventricular with the narrow complex, first is sinus tach, and you're going to see a PUA followed by a QRS. Usually it's not super fast. Often it's not greater than 150, 160. And if somebody has sinus tachycardia, you have to figure out why. Are they septic? Are they thyrotoxic? Are they severely dehydrated? Is there a severe anxiety? There has to be a pulmonary embolism. There has to be a reason. Heart failure, an acute MI, there has to be a reason for the sinus tachycardia. AV nodal reentry and a flutter could be confusing because you're going to see PUA, you're going to see QRS complexes that are narrow. You're going to have a regular rhythm, and you may or may not see P waves buried. Now, with a flutter, sometimes you see flutter waves, sometimes you won't. And what you can do here are vagal maneuvers, such as have patient do Valsalva or immerse their head in water. And sometimes they do carotid massage, but you got to listen to make sure they don't have a bruit, they don't have diffuse atherosclerosis. You don't want to precipitate a stroke. And if it slows down but doesn't break, that can tell you you're dealing with a flutter. And if not, okay, and if it either breaks or doesn't break, then you can think of re-entrant AV nodal with the circus movement tachycardia, and you can treat that. The first line drug, if the vagal maneuvers don't work, you would give IV adenosine. AFibs are regularly irregular. Rapid response, sometimes the response isn't rapid, it's a common arrhythmia. And if somebody is AFib, you're going to think of rate control, you're going to make a decision on rhythm control and anticoagulation. Multifocal atrial tachycardia, is something you see where it's irregularly irregular, and you have P waves before a QRS complex, but you have P waves of three different morphologies. Okay, you often see that with people with COPD and hypoxia. You don't see that in healthy people. And then there are other atrial tachycardia. It's not as common, and you'd have to discuss this with EP people about that. Someone is a bradycardia, if they have sinus bradycardia, you have to ask why. If it's a younger person or an athlete, it may be physiologic. An old person, it might be sinus node conduction disease. Then you look for heart blocks. First would be heart blocks at the AV node. You see a prolonged PR interval. They may or may not be bradycardic. Second degree heart blocks at the AV node. You will drop a beat, but you'll progressive lengthening of the PR interval and narrowing of the RR interval. That's what's called the Wiggy-Bot phenomenon. If you have sinus bradycardia arrhythmia where you just drop a QRS complex and the PR interval doesn't increase or the RR interval doesn't decrease, that's moments two. Severe conduction block, they need a pacemaker, and complete heart block is where nothing's going from the atrium to the ventricle. Now, if there's a narrow QRS complex, then the recovery pacemakers at infranodal, but it's in the His-Purkinje system before you go into the ventricles. Often there'll be wide ventricular, wide QRS complexes, and these people need pacemakers often emergently. So this is a quick overview on arrhythmias. Thank you.